welcome all to the class. So today's topic, we will before we start with today's topic, we will have very frequently asked questions. Okay, uh, if you have read the guidelines, in the guidelines there are two tables which you see. One is level of evidence, and second is a grades of recommendation. We read the whole of the guideline, but most of the time we neglect these two tables. But sometimes there can be SBA or there can be EMQ also on this particular topic. So today's we will finish these questions and then we will go for the today's main topic. Okay, and if you have read the consent, okay, in the consent we are talking about the various risks which are involved in the procedure, in the operative. So that is called as risk information. And the way we describe is 1 in 10 or 1 in 10,000. But when we talk with the patient, then how it is to be spoken, and like common, uncommon, and what does it mean? Okay, so that we are going to see. You maybe ask about the SBA or EMQ on this. Okay, so first we'll see about the risk information. Okay, so whenever we are talking about the information on any risk, what are the terms which are commonly used while talking with the patient? That very common. Then we talk about the common risk. Then we say that it is an uncommon risk. Sometimes we say that it is a rare risk, and sometimes say that it is a very rare. Okay, so what does this very common mean? When the risk involved is 1 in 1 to up to 1 in 10, that is almost a person in the family is likely to have that particular risk. It is that common. We label this as a very common. Okay, so in numerical ratio, it will be 1 is to 1 to 1 is to 10. Then we have some common risk. Okay, that is described as a in the numerical 1 in 10 to 1 in 100. That is, in colloquial language, it will be a person in the street is likely to have such and such condition. Okay, so same about uncommon, from 1 in 100 to 1 in 1000. That is, in colloquial equivalent is a person in the village. Then rare condition, that risk is 1 in 1000 to 1 in 10,000. That is, a person in small town is likely to have this particular condition or likely to have this particular risk. And when we say very rare, that means the risk is less than 1 is to 10,000. Okay, that is a person in the large town. So these are the things which are commonly asked, used, and they ask you any of this, and they will ask you what does this uncommon risk means. Okay, so this is one of the SBA. Okay, so this table you should know well. Okay, so now we'll have you understood this? 1 in 10,
Yes,
1 in
sir.
1 in 100, 1 in 1000. So very common, common, uncommon, rare, and very rare. So just see this question if you can answer this question.
Yes, sir. During counseling before an elective cesarean section, you explain the risk of accidental bladder injury. You state this is an uncommon complication. Which option correctly represents both its equivalent numerical ratio and colloquial equivalent? Um, yes, uncommon, very common, common, uncommon. It is 1 in 100 to 1 in 1000. Option B, a person in a village.
Uncommon. Okay. So what is uncommon? It is 1 in 100 to 1 in 1000.
1 in 1000 in a village.
So remember, village, generally the village population, small village, up to 1000, a small area where there is a locality, it is up to 1000 population. That corresponds with the uncommon. Okay. Then we have 2 on this side, 2 on this side. Okay. Then after the village, it is a small town. So maybe 10,000 population, and large town maybe less than, the risk is less
10,
than.
1.
Yeah. Okay, it is something like that. So you remember in this particular way. So go for the next question. So the answer for the first question, in operative risk, uncommon means the frequency is between 1 in 100 to 1 in 1000. 1 in 100 is on the street, a person in the street. Okay,
Okay.
and 1 in 10 is a
When
person in the family. Okay, yeah, go ahead with the question number 2.
when obtaining consent for laparoscopic sterilization, the patient asks about risk of fatal complication under general anesthesia. You describe this as very rare. Which option below gives the correct equivalent numerical ratio and colloquial equivalent? It will be D, less than 1 in 10,000, a person in a large town.
Actually,
Very rare.
these questions are very simple, but sometimes we get confused. Okay, that is why I'm covering specifically these 2-3 questions. Now the subsequent topic will be more confusing. Okay, so the answer for this question was a D, that is very rare operative risk occur in a fewer than 1 in 10,000 cases comparable to a person in a large town. Okay, now we'll go ahead with the grades of recommendation. Okay, so first
Yes.
thing, there are two things. One is a level of evidence and second is a grade of recommendation. Okay, so the recommendation will be based on the level of evidence. Okay, so what is the level of evidence? From that we make the recommendation. This recommendation can be graded as a grade A, B, C, D and P or GPP, that is a good practice point. Okay, so these are the grades of recommendation: A, B, C, D and P. Okay, so these are the grades of recommendation. Okay, now what does the grade A recommendation means? This grade A recommendation means this recommendation is derived from at least one meta-analysis or systematic review or RCT which is rated as 1++ directly applicable to the target population, or systematic review of RCT or a body of evidence mainly rated as 1+ directly applicable and showing overall consistency of results. Okay, so here when we talk about grade A, what do we mean? It is based on the SR and MA. Think of systematic review and meta-analysis. Think of RCT, which are graded as 1++ or 1+. Okay, so this evidence is coming from the uh, either systematic review or meta-analysis of RCTs, which are graded as 1++ or 1+, directly applicable and showing the overall consistency of the results. Okay, when we talk about the grade B recommendation, it is based on the body of evidence including the studies which are rated as 2++, directly applicable to the target population and showing the overall consistency of the results, or it is extrapolated evidence from the studies rated as 1++. Doctor, can you unmute yourself? Dr. Sinchana, can you unmute yourself? So body of evidence, so grade B, the body of evidence including the studies which are rated as 2++, directly applicable to the target population and showing overall consistency of the results, or extrapolated evidence from studies which are rated as 1++ or 1+. Okay, so grade A is directly 1++ or 1+, and it involves the meta-analysis or systematic review of RCTs. Okay, while in grade B, what we have, the studies are rated as a 2++. Okay, or it is extrapolated from 1++ and 1+. Okay, so it is either extrapolated evidence from this or it is coming from 2++ studies. Okay, now grade C, that is the body of evidence including studies which are rated as 2+. Okay, remember here it is coming 2+. So when it comes A, both are there, 1++ plus 1+ is there, while in grade B we only have 2++ and extrapolated from this. Okay, 1++ and 1+. Then in grade C, what we have, in grade C, what we have, only 2+ and extrapolated evidence from 2++. Okay, then grade D is evidence level 3 or 4 or extrapolated evidence from 2+. Okay, and P stands for good practice point, recommended best practice based on clinical experience of the guideline development group. Okay, so it is a recommended best practice based on the clinical experience of the guideline development group. That is labeled as a P. Okay, so how to remember this? When we talk about A, that is the strongest evidence and it will be based on SR or MA of RCT, which, and we will have 1++ or 1+ studies. Okay, and directly applicable with a consistent results. So these are the key words you remember. Grade A is the strongest evidence and it will depend upon SR or MA from the studies which are rated as 1++ or 1+, and it is directly applicable to the population having the consistent result. Okay, next level is a grade B. It is a high quality cohort or case control studies which are rated as 2++, or it is extrapolated from grade A evidence. Okay, so here studies what we are getting are the case control and cohort. So here they were RCTs, here we are getting case control or cohort. They are labeled as 2++, and it is extra, or it can be extrapolated from this. Then next is a C, that is a moderate level of evidence we have, which is again case control or cohort, but these are 2+ studies or extrapolated from the this particular 2++. Okay, then we have grade D, that is the lowest, either case series or reports, that is level 3 or 4, or it is extrapolated from this. Okay, then we have P, that is practice points. That is how you remember. A has got SR and MA of RCTs 1++, 1+. B will have SR and MA of cohort and case control studies. Okay, but the studies are 2++ or extrapolated from here. C will have only 2+ or extrapolated from 2++. The D is the lowest one, that is case series and case reports. Very easy to remember. D is the lowest, case series and case reports, or it is extrapolated from 2+. So when they ask you about D, no, don't select the option with case series and case report. You select completely. So this extrapolated from 2+, you may have two options. One is a case series, case reports, level 3 or 4, and another option will be this complete sentence. So this complete sentence you should remember. P is practice point, what we have discussed. Now how to remember? A simple mnemonic to remember the order is all best care delivered promptly. Okay, you can note it down in your notes later on. Okay, A is a top, which involves RCT. B is the next best. Okay, B stands for best. So after RCT comes this case control and cohort studies. Then 2++ we have, and here it will be 2+, and it will always be extrapolated from A+ will be in the B, extrapolated from 2+ will be in the C. Okay, sorry. And D is the lowest one, that is level 3, level 4, or extrapolated from 2+. Okay, so that is how you should remember. So now coming to the evidence grading in clinical guidelines. So here Dr. Sinchana, can you read these two questions?
Yes, sir.
Yeah.
STEM 1. A guideline statement says this recommendation is based on body of evidence, including study rated as 2++, directly applicable to target population and showing overall consistency of results, or extrapolated evidence from studies rated as 1++ or 1+. Which grade of recommendation best fits this statement? This is
These are
grade. Um, it is grade B studies. Either it is studies directly rated as 2++, directly applicable, or extrapolated from 1++ or 1+.
correct, correct. Okay, next.
STEM 2, a guideline statement says the recommendation is based on body of evidence, including studies rated as 2+, directly applicable to target population and showing overall consistency of results, or extrapolated evidence from studies rated as 2++. Uh, this is a grade C recommendation.
So option C. Okay,
C.
so yeah, but when you see all the options, you are likely to get confused. Okay, so that is
Yes,
why
yes.
make a habit of understanding the concept very clearly. Okay, so the correct answer is B, and here correct answer is C. Okay,
Yes.
now we'll go ahead with the level of evidence or the classification of evidence levels. Okay, now how the evidence levels are classified? They are classified as 1++, 1+, 1 minus, then 2++, then we have 2+, 2 minus, then 3 and 4. Okay, so now simple, we'll learn first 3 and 4. What are these 3 and 4? 3 is non-analytical analytical studies, that is case reports and case series. Very simple to remember. Case 4 is just an expert this level 4 is an expert opinion. Okay, now here we have to remember this 1++, 1+, 1 minus, 2++, 2+, and 2 minus. So these are the things we should remember. Okay, now what does 1++ means? It is a high quality meta-analysis or systematic reviews of RCT or RCT with very low risk of bias. Okay, so we have RCTs high quality with very low risk of bias. Okay, 1 plus. Then 1 plus what we have, well conducted meta-analysis and systematic review of RCT. Again, we are talking about RCTs only, but low risk of bias. Here it is a very low risk of bias. Here it is a low risk of bias. Okay. Then we have 1 minus. Again, we have meta-analysis or systematic review of RCTs, but we have got a high risk of bias. So when we talk about 1, as such, we have common RCTs, but the bias differs, very low risk and high risk of bias. Is it clear?
Yes,
Is it
sir.
clear? Yeah. Okay.
Yes,
Now
yes, sir.
let's come to the 2 plus plus, 2 plus and 2 minus. We had RCTs here, so we will have case control and cohort studies. Okay, here. So we will have high quality SR systematic reviews of case control and cohort studies, or high quality case control or cohort studies with very low risk of confounding, bias or chance, and high probability that a relationship is causal. Okay. So what we have here, we don't have RCTs, we have case control or cohort. Okay, they are high quality, but we know in the that pyramid, the best are the RCT, followed by these particular case cohort and case control and cohort. Okay, so here we have high quality systematic reviews are there, but involving mainly case control and cohort studies, but there is a very low risk of confounding or bias, and there is a high probability that the relationship is a causal. So likely to be high possibility of causal relationship. Now let's come to the 2 plus. Here again, what we will have, the case control and cohort. However, the risk of confounding bias will differ. Okay, so they have a low risk of confounding and bias. So well conducted case control and cohort studies with low risk of confounding, bias or chance, and moderate probability that the relationship is causal. Okay, these are 2 plus. Okay, so understood the difference? Here case control cohort, very low risk of confounding, here low risk of confounding or bias. Here high chance probability that the relationship is causal, moderate probability that the relationship is. Now coming to the 2 minus. In 2 minus, again we have case control or cohort with high risk of confounding, and significant risk is that the relationship is not causal. So it is not giving any causal relationship to that particular factor. Okay, so in 2 minus, again we are dealing with the case control and cohort. There is a high risk of confounding and bias, and the relationship is not causal. Okay, that is how this 1 and 2, then either plus 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 or minus you should remember. Is it clear to you?
Yes, sir.
Yeah. So now how to remember? 1 plus plus, best quality RCT and MA with very low risk of bias. Here again RCT and meta-analysis, good RCTs and meta-analysis, low bias. Here it is poor RCTs, meta-analysis, high bias. Okay. Now coming to the this 2 plus plus, these are case control and cohort or observational study, but they are best. Okay, and very low risk of bias, likely causal. Here probable or the moderate possibility of the causal, but the bias is low. Same case control cohort. Here it is poor observational, means case control and cohort, high bias and unlikely causal. Okay, 3 and 4 we remember easily. These are non-analytical case reports and case series, and this is expert opinion. So that is how you should remember these particular study. Okay, so just we'll have these 2 questions. If you can solve these 2 questions, give a try.
Yes, sir. A guideline recommendation is supported by well-conducted meta-analysis, systemic reviews of randomized control trials or randomized control trials with a low risk of bias. What level of evidence best fits this? This is 1
Yeah,
plus.
correct,
1
correct.
plus.
If it would have been 1 plus plus, then what would have been changed here?
It will be high quality meta-analysis, and it will be very low risk of bias.
Correct, correct. Okay, so these keywords you should remember. Next, go ahead with the next.
A recommendation is supported by high quality systemic review of case control and cohort studies, or high quality case control cohort studies with very low risk of confounding bias or chance and a high probability that relationship is causal. Level of evidence is 2 plus plus.
Correct. So what features? First thing, we are dealing with the case control and cohort.
High
They are
quality.
high quality.
High
Okay, and
quality, very low risk
risk,
of
very low risk,
confounding interest,
relationship,
and high.
probability, high probability. Okay, so these are the keywords we should be able to pick up and then analyze. Okay, so when you look at these answers now, we are likely to get confused. So whenever any EMQ you are solving, when you read the stem, at that time you should understand, or you should have the probable answer in front of you, then search for that option and then see is there any other best option apart whatever you have selected. Is that right? Have you understood the
Yes,
way of solving the EMQ now? Okay, so you should
yes,
come,
sir.
don't look at the answers first. Okay, so that finishes the today's topic. So correct answer for the first is B, then it is answer B. Okay, so that finishes today's topic. Thank you. Yeah. Welcome all to the today's class of emergency obstetrics, in which we have next topic as a VASA previa and cord prolapse. Okay, so this topic is going to be very important, and this is a green top guideline, very frequently asked in the examination. So first we'll learn about VASA previa. Okay, so what about the what is the definition of VASA previa? Actually, in VASA previa, what we have is the fetal vessels which run in the pre-placental membranes, which are unprotected by the placental tissue or the Vartan's jelly. Okay, so these are the fetal vessels which run through uh, free placental membranes, and it is unprotected by placental tissue or Vartan's jelly. The risk of rupture likely during the active labor or amniotomy. Okay, especially if they are near or over the cervix under the presenting part, the risk of rupture is high. There are two types, type 1 and type 2. Remember, type 1 is a filamentous cord and type 2 is associated with the subcentriate lobe. Okay, we'll see this in the subsequent figure. Okay, so this is a type 1. So what is type 1? Type 1 is associated with filamentous insertion of the cord. So this cord is getting inserted into the membrane. Okay, and here is a placenta, and here there is a feeding vessel to this particular cord. Okay, it is lying free in the membrane. This is type 1 type of VASA previa. In type 2, what we have? We have a this subcentriate lobe. Here is a main placenta. Here is a cord, and there is a vessel which is connecting this subcentriate lobe to the main placenta. So this becomes the VASA previa, that is type 2. Okay, so these are the two types. Is it very clear to you? Type 1 and type 2. Type 1 is a filamentous and type 2 is associated with the subcentriate lobe. Okay, yeah. So what are the key points? First is emergency cesarean delivery. If VASA previa ruptures during the labor, then what? Another thing is the neonatal resuscitation facility should be available and should include the blood transfusion if required. Remember, when the VASA previa bleeds, the bleeding is going to be from the fetal aspect. So the not only neonatal resuscitation, but the blood transfusion may also be required. And third is a placental pathological examination to confirm the diagnosis, especially if there is a stillbirth or acute fetal compromise. Okay, so whenever there is a scenario about the VASA previa, you see what exactly they have given, but option with neonatal resuscitation, including the blood transfusion and placental pathological examination, these three things are very important. Okay, now how it is diagnosed. So diagnosis in labor by vaginal examination, what we feel is a pulsating fetal vessels at the internal os. There may be dark red bleeding and there may be acute fetal compromise after the membrane rupture. Okay, now if it is not diagnosed antenatal, so it happens during the labor, what is the mortality? And if it is diagnosed antenatally, then what is the mortality? Okay, so if the condition is directly diagnosed in the labor without antenatal diagnosis, then fetal mortality is high, more than 60% despite urgent cesarean. Okay, so high fetal mortality to the extent more than 60%. Sometimes they ask you the survival rate. So survival rate will be around 40% if the condition is not diagnosed, while prognosis with antenatal diagnosis will be 90%, 95% survival with ultrasound detection and planned cesarean section. So good survival rate with antenatal diagnosis. Okay, then what is the prevalence? It happens in 1 in 1200 to 1 in 5000 pregnancies. Possibly it is underreported. So these are the few important things about the VASA previa. Then what is the emergency management? Immediate cesarean delivery along with the neonatal resuscitation, SOS if required blood transfusion, we have to carry out, and after delivery we will send the placenta for histopathological examination for confirmation of the diagnosis, especially after the stillbirth or acute fetal compromise. Okay, then classic presentation in the labor, it is a painless vaginal bleeding or Benseker's hemorrhage, usually after Benckiser's hemorrhage after cervical dilatation and spontaneous artificial membrane rupture. Then fetal risk, fetal blood volume is approximately 80 to 100 ml per kg. Even small blood loss can cause rapid fetal death. Okay, this is SBA. They ask you about the normal fetal blood volume. It is around 80 to 100 ml per kg. This is a frequently asked question. Okay, so here lies a SBA 80 to 100 ml is the answer. And what does the evidence says? As evidence coming from systematic review and meta-analysis says that the perinatal death risk is 4.5 times raised with VASA previa. Okay, so perinatal mortality is high with VASA previa. Then what is the accuracy of diagnosis? High diagnostic accuracy with low false positive rate with routine anomaly scan, best with combined transabdominal and TVS CDI, that is a color Doppler imaging. So what is the best modality will be transabdominal plus TVS CDI, color Doppler imaging. Clinical diagnosis is not reliable. Clinical method with is not very reliable. Vaginal bleeding in pregnancy has got low predictive value because there are n number of causes for the vaginal bleeding. Okay, so definition we have seen that vessel in the pre-placental membranes within 2 centimeter of the internal cervical os. This definition is modified after the definition of the low-lying placenta. Okay, so generally there is a vessel lying in the free placental membrane within 2 centimeter of the internal os. Timing of screening, around 18 to 24 weeks of gestation, that is somewhere around the malformation scan, and confirm this at 32 weeks of gestation. Okay, so diagnostic, what we have seen, TVS CDI color Doppler imaging in the second trimester, sensitivity is high. Then outcome prenatal, if you diagnose 97% survival rate, we have already seen more than 95% survival rate condition diagnosed, while 44% only they have mentioned 60 more than 60% mortality, and survival will be 44%. Okay, if diagnosed intrapartum. Okay, so these are the important things to learn regarding this. So what are the key points? Universal screening, these are the what we have seen up till now, these are the modalities which are available, but then should we screen all patients? So what does the guidelines say? That universal screening is not supported. There is insufficient evidence for general population. Mid pregnancy anomaly scan is general population has undetermined benefit to harm balance. Okay, so all population not to be screened for this. Okay, what does UK NSC review says? That is National Screening Committee. UK National Screening Committee says there is a little benefit in identifying VASA previa in the second trimester, high false positive rate, and around 80% of cases will have more than one identifiable prenatal risk factor. There is no UK epidemiology data for filamentous cord insertion, no evidence to support screening for filamentous cord insertion as a proxy. Okay, so targeted screening for high risk group is preferable. So they don't recommend universal screening, but what they say that high risk group can be screened because more than 80% will have more than one identifiable risk factor. So these high risk patients can have the targeted screening. Okay, so what are the risk factors? 83% of VASA previa will have more than one risk factor. These common are placenta previa, bilobe placenta, succenteriate lobe, ART conception, and filamentous cord insertion. So these are the high risk factors which are associated with the VASA previa. Okay. Now this Australian maternal obstetric surveillance data is there. So what they say that here again more than one risk factor in almost more than 90% of cases, and filamentous cord insertion is seen in 62% of cases, and low-lying placenta in 60% of cases. Okay, that was a I think Australian study. It is there. So they have mentioned about these are the placenta previa, bilobe placenta, centroid lobe, etc., etc. These are the risk factors, out of which here the all the options are given. Then filamentous cord insertion appears to be more common than low-lying placenta. Okay, and 20% of the second trimester VASA previa will resolve before delivery. So even if you diagnose second trimester, 20% will be resolving before delivery. And if you have diagnosed that, then we have to follow up at 32 weeks of gestation, especially when associated with the low-lying placenta. Okay, and you have to document the cord insertion. Okay, And this American ultrasound medicine, this what do they say? You have to document the placental cord insertion when possible. Okay, American Institute of Ultrasound Medicines mentions that you should document the placental cord insertion wherever possible. So what are the summaries up till now? We have seen universal screen, insufficient evidence. Okay, targeted screening, benefit versus harm, still not clear. More research is required. Then UK National Screening Committee, what does they say? 80% cases have more than one identifiable factor. Little benefit from the second trimester screening, high positive rate, and do not implement universal screening. Consider limited target approach for high risk groups. Okay, like low lying placenta, etc. Okay, then we have seen 83%. Then these are the high risk factors which are associated with the VASA previa. Okay. So management of the VASA previa, what are the summary points? First thing about we have to go for emergency delivery. Do not delay delivery if fetal compromise is suspected. There is a high mortality with rupture. Immediate cesarean section if PROM or labor at viable gestation. So if the gestation is viable, you go for immediate cesarean section or category 1 cesarean section. We'll discuss about all categories subsequently in our sessions. Okay. Then elective delivery. Confirm VASA previa in the third trimester. Elective cesarean section before the onset of labor. Okay. If it is confirmed in the third trimester. Then hospitalization. Consider from 30-32 weeks based on the risk factors like multiple bleeding, threatened preterm, etc., etc. And so these are the few summary points. Then ultrasound confirmation, we have to reassess in the third trimester to confirm the persistence before planning delivery. Cervical length, if the cervix is becoming very short, then these patients are likely to bleed. Okay, or they are likely to land up in the problem. So that is one of the thing which they have mentioned. So timing of elective delivery in VASA previa. So all timing of the delivery in all cases you should know. So what is the timing for VASA previa? Goal is deliver before membrane rupture while minimizing the iatrogenic prematurity. So recommended timing is between 34 to 36 weeks. Remember, VASA previa 34 to 36 weeks when patient is asymptomatic. So you will plan the cesarean section between 34 and 36 weeks, and corticosteroids from 32 week onwards. So most important, 32 give corticosteroids, and plan cesarean section 34 to 36 weeks. Then evidence and rationale, here longest course was 97% survival when the delivery is around 35 weeks of gestation. Okay, so that is what is the thing, and you don't have to wait for amniocentesis or something like that. 34 to 36 weeks, if you deliver, the outcome is good. So that finishes the VASA previa. Thank you. Welcome all to the next topic. So the next topic is umbilical cord prolapse. Again, this is a green top guideline number 50. We begin with our tagline, master MRCOG with concept oriented clarity. So umbilical cord prolapse, what are the key recommendations? What are the risk factors for the umbilical cord prolapse? The clinician should be aware of multiple clinical factors which increase the risk, like malpresentation, high presenting part, polyhydramnios, multiple pregnancy, etc. Antenatal detection, routine ultrasound is not sensitive or specific enough, so not recommended for predicting the cord prolapse. Okay, selective ultrasound may be considered for term breech pregnancies planning vaginal birth. Okay, so these patients, you have a term breech and planning vaginal birth, you should screen these patients for umbilical cord prolapse. Okay, then what are the prevention strategies? Especially when you have unstable or transverse or oblique lie, discuss elective hospital admission after 37 weeks of gestation. In the community, patient should be instructed that she will report once the labor starts or the rupture membranes are ruptured. If it is a non-cephalic and preterm premature rupture of membrane, recommend inpatient care. Okay, and when you do ARM, avoid ARM, especially when the presenting part is high or mobile, and if necessary, ensure immediate C-section availability. Okay. What about the vaginal examination? When you are performing the vaginal examination, minimize upward pressure on the presenting part in a ruptured membrane. So when the membranes are ruptured, to see the liquor and all, don't push too high, okay, this presenting part, and avoid rupture of membrane. If the cord is felt below the presenting part, then the rupture of the membrane is to be avoided. Okay, when you feel that the membranes are intact and you are feeling the cord, avoid the rupture of membrane. Now, what is the management in labor? Cord presentation is diagnosed in established labor, usually requires cesarean section. Now, when to suspect the cord prolapse? Routine checks like exclude cord presentation or prolapse at every vaginal examination in labor, and after the spontaneous rupture of membrane, if there are risk factors. So patients with risk factors always suspect the cord prolapse and rule out the cord prolapse. Then auscultate fetal heart rate after each vaginal examination, and after SROM, you will auscultate the fetal heart rate. What are the suspicious signs? Main is an abnormal FHR pattern, especially after the rupture of membranes. Immediate action is perform speculum and or digital vaginal examination if the cord prolapse is suspected. So what is the next step when you suspect? They may give you a scenario that the membranes are ruptured, the CTG is showing abnormal FHR. What will be the next step? Perform speculum examination or digital examination to rule out the cord prolapse. We are suspecting the cord prolapse. So these are the concepts which you should understand. Okay. Uh, uh, Sometimes they ask you the next step and you discuss about the management. Shift the patient for cesarean section. Read carefully what is asked in the step. Okay. And if there are no high risk situation in that particular case, if the membranes rupture, FHR is normal, and there are no risk factors, the routine vaginal examination is not indicated. Okay, but high risk patients always do the per vaginal examination and FHR. But FHR you have to always check whether it is a low risk or high risk patient. Okay? The initial management of cord prolapse in the hospital setting. Cord prolapse can happen in the community setting, it can happen in the hospital setting. Now, if it is in the hospital setting, what is expected? First immediate action will be call for urgent assistance, prepare for immediate cesarean section, usually category 1 cesarean section it will be. Avoid manual replacement of the cord above the presenting part, it is not recommended. Okay, excessive handling is to be avoided because it causes vasospasm. Okay, so excessive handling should be avoided. Then relieve cord compression. Remember this, that elevate presenting part manually or bladder filling. They ask you the next step. You have done the first will be the call for assistance. Okay, first will be the call for call. Second will be avoid manual replacement, and then relieve the cord compression by manual replacement or by bladder filling. And what will should be the position of the patient? Either knee chest position or left lateral head down, pillow under the hip. So these are the positions: knee chest position or left lateral head down, pillow under the hip. Okay, this is the position in the hospital setting. Okay, and consider tocolysis if FHR remains abnormal and delivery will be delayed. So if the scenario says that these are the findings you have done up till now, this is done, this is done, this is done, the FHR is abnormal and the OT is busy, previous section is being is over and it will take 10-15 minutes to get shifted, then we might have to consider the tocolysis if the FHR is abnormal and delivery will be delayed. Okay. So the scenario, if you read carefully, you will understand what exactly they are expecting. So what is the principle? These measures must not delay definitive delivery. So definitive delivery is the main management here. Then mode of birth in the cord prolapse. Generally, it is a cesarean section. So preferred method is a cesarean section if vaginal birth is not imminent. Then it may be category 1 cesarean section or category 2 cesarean section. Category 1 cesarean section, you have to deliver the baby within 30 minutes if the FHR abnormal. If the FHR are normal, fetal heart rate is good, with continuous monitoring, you may consider category 2 cesarean section. However, when this FHR becomes abnormal, then again you will shift from category 2 to category 1. Okay, so category 2 limit is 75 minutes. Category 1 is within 30 minutes you have to deliver. Okay. Now anesthesia. Discuss with the anesthetist. If possible, regional with the experienced team and verbal consent is acceptable for category 1. Remember, what type of consent here? If it is that severe emergency, then even the verbal consent is acceptable. You have to document the things, what was the situation. Okay. Then vaginal birth. It is possible when this patient is fully dilated, it is delivery is quick and safe, and avoid the cord compression. Then which extraction is acceptable in specific cases, like there is a second twin after IPV, after internal podalic version, the second twin is with cord prolapse, then go for breech extraction. The neonatal care, skilled newborn resuscitator must be present, and always take paired cord blood for pH and base excess. Okay, so if you in the preparation, either the delivery will be by the category 1 or category 2 cesarean section, or there may be breech extraction, or there may be instrumental delivery if the patient is fully dilated, but the pediatrician should be ready, and paired cord blood sample for pH and base excess we have to collect. Okay, so these options, look for these options in the of your question. Okay, then cord prolapse, how will we manage in the community? Now actually doctors will not go into the community, but the scenario may mention that the community midwife has attended such and such, and she gives you the call, and then you are going to instruct certain things. So you have to read the scenario carefully and look for the appropriate answer from this particular slide. Okay, so in the community it is always a risk assessment. So when the patient comes for the booking and asks for the home birth, at that time whether this particular patient is suitable for home birth or not. Okay, even at the labor onset, whosoever the midwife is attending, whether this patient is suitable for the home birth or not, all these things are to be assessed. Okay, then immediate advice, if there is a cord prolapse, then at home adopt knee chest face down position until transfer. Okay, so if the ambulance is yet to come, then the position will be knee chest face down position. Okay, during the ambulance transfer, it will be exaggerated seams position, left lateral, pillow under the hip. Okay, so they may ask you that the midwife has attended the call and asking for the further advice. You see what information is given, accordingly you select the option. Then during the transfer will be exaggerated seams position, left lateral, pillow under them. Then transfer to the nearest consultant led unit unless vaginal birth is imminent and safe. Relieve cord compression by elevation of the presenting part manually or by bladder filling. Okay, community midwives should carry Foley's catheter and infusion equipment. So this particular advice is sometimes also expected, that generally they have the Foley's with them and infusion equipment, so they should feel the bladder, okay, and elevate the presenting part. Then cord handling is to be avoided. Avoid excessive handling of the exposed cord to prevent vasospasm. Okay, so this is what is the management in the community. Is it clear to all of you? Dr. Sinchana, Dr.
Yes.
Indra? Yeah.
Yes.
Yes, sir.
So cord prolapse around the time of threshold of viability, if it is a extreme premature 23 to 24.6 weeks of gestation, the management option, you can discuss the expectant management because it is a threshold of viability. Okay, discuss the expectant management in this gestational age. No evidence supports replacing the cord into the uterus at or before this stage. Counseling advice for both continuation and termination of the pregnancy. So it is a shared decision making. And delayed cord clamping, what does they say? They are saying consider if newborn is stable and prioritize immediate resuscitation if the baby is unwell. So it will depend upon the stability of the baby. Okay, these are few clinical governance points. We have to talk to the relatives, explain the events whatever have happened. Then you have to train the staff. Then we have to go for incident reporting and documentation. These are for part 3, not for part 2, but just remember. So whatever we have seen up till now was regarding the cord prolapse were the key recommendations. Now we will go into the details of this. So what is cord prolapse? It is a cord prolapse. Umbilical cord descends through the cervix alongside, that is occal cord prolapse, or the past overt cord prolapse presenting part with the rupture of membrane. Okay, so the umbilical cord descends through the cervix alongside, that is the occult, or it may be overt when it is past the presenting part with rupture of membrane. Then what is cord presentation? Cord is between the presenting part and the cervix with or without intact membranes. Remember the incidence, the 0.6% is the incidence for cord prolapse, 0.12, or sometimes they will give 1 in 200. Okay, so that is 0.5% comes. Okay, overall 0.1 to 0.6%. Breech presentation will have 1% incidence. Okay, so cephalic will have half of that. Okay, half higher in multiple gestations. Then impact on outcomes, features in parental mortality review. Parental mortality is 91 per 1000. Okay, made adverse outcomes will include prematurity, congenital malformation, birth asphyxia, etc. Pathophysiology, Cord compression, umbilical arterial vasospasm leads to the impaired blood flow to and from the fetus. Okay. So now, what are the general risk factors associated with the cord collapse? Multiparity, low birth weight, preterm labor, congenital anomalies, breech presentation, transverse, oblique, unstable. These all factors we know. Okay. Then procedure related will be ARM with high presenting part, vaginal manipulation with ruptured membrane, external cephalic version, internal podalic version, stabilizing induction, intrauterine pressure catheter insertion, or large balloon catheter more than 180 ml saline for induction if it is used, that can displace the presenting part and will permit the cord to come down, and manual rotation of the fetus. So these are the clinical conditions in which there can be cord collapse. Key points: around 50% of the cord collapse cases follow obstetric intervention. So obstetric, we have just seen these were the conditions associated with the procedure related, and how many? 50% of the cord collapse will be associated with this. Risk increases when the presenting part is not well applied to the pelvis or lower uterus. Amnio infusion risk is unclear. Okay, so these are a few points which are important. Detection of cord presentation antenatal. Routine ultrasound is not recommended. This we have seen already before. So same thing. If it is a breech presentation, then weekly transvaginal scan for breech after 36 weeks with cesarean section for persistent cord presentation. Reduce cord collapse to 0 in 10 years. So if it is a breech presentation, then we can screen weekly after 36 weeks of gestation. Okay, and this will help women to make a choice regarding the vaginal breech birth. Okay. Now coming to the prevention of cord collapse. When we have abnormal lie, that is transverse, oblique, unstable, consider hospital admission around 37 weeks of gestation. Advise urgent presentation if there is a rupture of the. If it is a non-cephalic with PPROM, recommend inpatient care. Okay. Avoid ARM if the presenting part is high, mobile, or cord is felt. If necessary, ensure immediate cesarean section capability. Okay. Minimize upward pressure during examination. Interventions in ruptured membrane. Cord presentation in labor will require cesarean section. Labor and rupture of membrane with abnormal lie, usually immediate cesarean section. Decision depends upon the gestation. Okay. What does the NICE say? Assess engagement before induction. Avoid ARM if the head is high. This is what is the NICE recommendation. We have to assess for engagement before induction of labor and avoid ARM. Okay. So these are actually many points we follow in our day-to-day practice. So when to suspect the cord collapse? Check for cord presentation or prolapse at every vaginal examination and after SROM if risk factors are present. So if the risk factors are present, we have to do the vaginal examination, okay, in labor and after SROM. Auscultate FHR after every vaginal examination and after SROM. Now, what are the suspicion triggers? If there is abnormal FHR soon after rupture of membrane, especially bradycardia or variable or prolonged deceleration. High presenting part or polyhydramnios after rupture of membrane. Then diagnosis will be prompt vaginal examination or speculum examination if suspected. No routine vaginal examination after SROM if FHR is normal and there are no risk factors. Okay. Now, optimal initial management of cord collapse. So hospital setting we have already discussed. It is emergency cesarean section, that is category 1 cesarean section when the patient is not fully dilated. Avoid manual cord replacement to continue the labor. Unnecessary cord handling is to be avoided and delay in delivery to be avoided. Prevent cord compression by elevating the presenting part manually or via bladder filling 500 to 750 ml of via Foley's. Okay. And that has to be emptied if it is a vaginal delivery. Okay. Remember this. Maternal position will be knee chest or head down, left lateral with pillow under the hip. Consider tocolysis, terbutaline 0.25 or 250 micrograms subcutaneously if FHR are abnormal and delay is likely to happen. Okay. Then cord care, avoid manipulation. Wrapping in the warm saline swabs not proven to be beneficial. Okay. What does the evidence say? Bladder filling, manual elevation linked to good outcomes and more effective if diagnosis to the birth interval is prolonged. So this is what is the concept which they are likely to test from the scenario. Okay, so they will expect you the bladder filling or manual elevation of the presenting part. Now cord collapse, if further, if it is a vaginal birth and that is imminent, then you go for expedite the vaginal delivery, maybe operative if needed, and avoid cord impingement. If vaginal birth is not imminent, then category 1 cesarean section or category 2 cesarean section, depending upon the FHR. Abnormal CTG, you will go for category 1 cesarean section, and normal FHR, you will go for category 2. And you will convert it to category 1 if the FHR abnormality arises. Anesthesia, regional, if there is expert person and the cord compression is relieved, then you go for regional anesthesia. Otherwise GA if it is urgent and safe. Okay, so it will depend upon whether we have relieved the cord compression or not. Okay, then special cases we may go ahead with the breech extraction. All births, the neonatal resuscitation team paired cord blood gases for pH and base excess. This also we have already seen. Okay, outcome, CS reduces perinatal mortality versus non-imminent vaginal birth. If birth is imminent, outcome is similar. Okay. Decision to delivery interval. Shorter DDI linked to the better neonatal outcomes. Aim within 30 minutes for cesarean section and within 20 minutes for operative vaginal delivery. So if you are anticipating delivery will not be within 20 minutes, then we might take the decision of our cesarean section. Okay. Instrument of choice will depend upon the operator skill. So if there is a vaginal birth which is imminent, expedite vaginal delivery. If vaginal birth is not imminent, category 1 or category 2 cesarean section along with the depending upon the fetal heart rate, breech presentation, breech extraction. So this is what is the key message. The anesthesia of choice, regional with expert provided the manual replacement is done. Otherwise GA. Okay. All births after the cord prolapse, neonatal resuscitation team, and this all we have seen. Okay. Then coming to the summary of optimal management in the community setting. Okay, risk assessment. Midwife should assess the risk of cord prolapse before approving home or low resource birth, and again at labor onset. If cord prolapse known at home, then advise knee chest face down position until transfer begins. Okay, knee chest face down position until transfer begins. During ambulance transport, seams position, left lateral with pillow under the hip. Hospital transfer to the nearest consultant led unit. Relieve cord compression by bladder filling or by manually because they are supposed to carry the Foley's catheter and fluid. Okay. Then cord handling to be avoided. Minimal contact to prevent the vasospasm. Warm saline swabs around the cord are not proven beneficial. Perinatal outcome in the community setting 10 times more higher when the cord prolapse occurs outside the hospital. So perinatal mortality is 10 times higher if the situation happens in the community. Okay, so these are the and key preventing factor during transfer is maintain presenting part elevated to reduce the cord compression. Then should delayed cord clamping be used after cord prolapse? DCC can be considered if the baby is uncompromised at birth. Okay, immediate resuscitation takes priority if the baby is unwell. Term infants, DCC may be beneficial, especially in settings with poor nutrition. Okay. Preterm less than 37 weeks, DCC up to 180 seconds linked to fewer transfusions and better stability. Okay. So generally they are not asking in the cord prolapse DCC. We have the next topic of this. Any one of you wants to go ahead with few questions, doctor? Whatever we have learned. Yes. Anyone?
Okay.
Yeah.
Yes,
yes. Start.
29-year-old primary gravida at 39 plus 2 weeks in active labor at 5 centimeter dilatation, presents with sudden deceleration in fetal heart rate to 80 beats per minute following artificial rupture of membranes. Vaginal examination confirms cord prolapse and the presenting part is high. So
Yeah.
for each scenario of cord
Yeah.
prolapse during
These
labor,
are
select the most
appropriate mode of birth.
select the most appropriate mode of birth from list above.
So first question, you have understood. Shall I show the options?
Yes. Yes.
This-
Option A, immediate category 1
A,
C section. B, category 2
category
section with continuous monitoring. C, operative vaginal birth. D, expected management. E, emergency research. This immediate category 1 cesarean section.
yes,
Okay. Next.
A,
Next.
A 34-year-old multiparous woman at 38 plus 5 weeks with spontaneous rupture of membranes during labor. Corporal axis confirmed she is 8 centimeter dilated with a normal CTG and fetal head at station 0. She can be put at cord prolapse with normal CTG.
Did the findings, everything normal CTG, 8 centimeter
8 centimeter.
dilated, station is at 0.
Expected management, but expected
Operative vaginal delivery. So,
Do you expect this patient will deliver in 20 minutes?
so multiparous.
she can deliver multiparas 8 centimeter dilated
Multiparous.
zero station.
Let's see what is the option. They have not given the answer is not given, but I think this should be the category 2 cesarean section because the
Okay.
FH is normal. Okay.
Okay.
Then next.
A 26-year-old G2P1 at 37 plus 4 weeks confirmed cord collapse during second stage. She is fully dilated and fetal head is at +3 station.
So here, what do you think? She is in the second stage. She is gravida 2 para 1. Okay. She is a
Yes.
multigravida, fully dilated, confirmed cord prolapse, and station is
Yes.
+3. Don't you think here the operative?
She'll deliver.
Yeah, no,
Vaginal
here
delivery and
also.
full dilatation.
But what about the FHR they have mentioned? Fully dilated,
They're
but
not
then,
mentioned.
Not
no, but
mentioned FH.
expectant management we have not discussed anywhere. See, if you see
Yes, sir.
all the slides, they are talking about expedite the delivery operative if needed. Okay, then
Yes.
operative in the means operative vaginal delivery. Okay,
Yes.
head load delivery quickly possible. So we are going to
Mm.
go ahead with instrumental delivery.
C-section.
No, here
Yes.
Operative
instrumental
vaginal
delivery.
Vagina.
delivery. Full
Station is
dilatation.
no,
Operative vagina.
operative vaginal delivery. Okay, either forceps or vacuum. And last we have seen the instrument of choice will depend upon the surgeon. Okay, comfort of the surgeon. Next.
A 31-year-old woman at 40 plus 1 weeks, twin pregnancy, second twin in transverse lie after first twin delivered. Cord collapse occurs after rupture of membrane.
Very simple here, straightforward.
Section. Immediate
Why section?
Immediate
category 2 sec.
Why category 2
Category 2
section?
sec.
Why category 2 section? Why not breech extraction?
breech extraction. Okay.
No,
Okay.
we'll go ahead with the breech extraction. No, 31-year with 41. First twin is delivered. Second twin is in transverse lie. Okay,
Okay.
so
Yes, sir.
already fully dilated. So breech extraction is possible. That also we
Yes,
have
sir.
seen.
Emergency B section.
Emergency breech extraction.
That finishes our topic. Thank you. So welcome all to the today's session. This session is a small session about clamping of the umbilical cord and placental transfusion. This is a scientific impact paper number 14. It is published in February 2015. Okay. So in the SIPs, that is scientific impact paper, there may be one or two SBS from the SIPs. So this is one of the important SIP. Okay. So what is our traditional practice is ICC, that is immediate cord clamping. It is a part of active third stage of the labor, where what we do ICC, give prophylactic uterotonic, and we do CCT, that is control contraction. So third, traditionally our active management involves ICC, CCT, and prophylactic uterotonic. Okay, so immediate cord clamping, prophylactic uterotonic, and control contraction to reduce the PPH. Okay, so that was a traditional practice. What does what is the effect on PPH? The prophylactic uterotonic clearly reduces the major PPH. Timing of the clamping has little impact on the blood loss. So what time you clamp the cord, it will not have impact on the blood loss. You are giving the uterotonic and it is preventing the PPH, and your timing of the clamp will not interfere with the amount of the blood loss. Now please concentrate on the definition. Okay, what is immediate cord clamping? It is within 30 seconds of the birth. Your baby is delivered and you clamp the cord immediately. That is within 30 seconds. It is called as ICC or immediate cord. Then second is a deferred cord clamping. That is clamping of the cord is deferred at least for 2 minutes after the birth. Okay. So this term, it is preferred over the delayed cord clamping. Deferred is preferred over the delayed. Okay, it is after 2 minutes. Okay, an intermediate or often unclassified is what is between 30 seconds and 2 minutes, that remains unclassified. Okay, now these particular timings which they have given, this is from the SIP. Okay, here 2 minutes only in the SIP you will get. We will see what are the other timings which are mentioned. Okay, what we have to do, we have to document. The best practice is to record the exact clamping time rather than relying on the arbitrary categories. So always document at what time after the birth you have clamped the cord and document it. Okay, now let us concentrate here. What does the FIGO and WHO says? FIGO and WHO they do not recommend ICC as a standard. WHO advises late clamping between 1 to 3 minutes. Okay, so here we are coming across the time of 1 to 3 minutes unless urgent resuscitation is needed. So when we talk about the delayed cord clamping, it refers to the 1 to 3 minutes as per the WHO. Okay, so as I mentioned, this is a figure from the SIP, scientific impact paper. But what does the WHO says? The delayed cord clamping is 1 to 3 minutes unless resuscitation is required. RCOG says clamp only as early as necessary based on the clinical assessment. So early cord clamping only depending upon the clinical assessment. Otherwise delayed. Okay. What does the NICE says now? NICE says avoid clamping in the first 60 seconds unless cord or heart rate concerns are there, and clamp before 5 minutes but support further delay if the woman wishes. Okay, so generally they ask either WHO or with respect to NICE, but it is never before 60 seconds. Okay, so 1 to 3 minutes you can remember, and NICE says not before 60 seconds and clamp before 5 minutes but support the patient's wishes also. Okay, so you will be able to remember these values. Okay, then what is the physiology of placental transfusion? What is the amount of the volume which is transferred? The term baby receives around 80 to 100 ml extra blood after the birth. So when you do the delayed cord clamping, the baby will receive around 80 to 100 ml of the blood. Okay, blood volume rises from 65 to 75 ml per kg to 90 ml per kg by this. Okay, effect of immediate clamping. What happens if you clamp immediately? It reduces the blood volume by 20 to 35%, depriving the baby of 20 to 30 milligrams of iron, which is enough for 3 months. So the baby is deprived of this much of iron. Generally it lasts for 3 months. Okay, this particular story. Then what happens in preterm babies? It may lose a proportionately greater blood and red cell volume. Physiology less, it is less understood about the preterms. Okay, then circulatory transition at birth. What happens? The umbilical flow slows down, the pulmonary resistance will fall down, and pulmonary flow rises. Okay, so these are the physiological changes which are happening, and cord flow may aid this transition. Risk of immediate clamping: it may impair the transition, and especially in preterm or compromising. So whatever these changes, what happens? The umbilical flow reduces, the pulmonary flow increases because the pulmonary resistance decreases, and if you clamp this immediately, it may compromise this particular transition. Okay, so that is why immediate clamping is not advisable. Benefits of delaying are it increases the blood volume. Longer delay may improve cardiorespiratory stability and blood pressure without further volume changes. Okay, that is why the delay is suggested. Now, these particular what exactly the immediate is, here they have mentioned 15 seconds, or previously we have seen 30 seconds. In preterm they say 5 to 20. We will not go into too much details of this. Generally SIP has got many figures, but SIP are very less commonly asked. I'm just going to discuss the important points from this SIP. We'll skip this. What is the conclusion between the term and preterm? Deferred clamping in healthy term infants is beneficial for iron stores and safe if phototherapy is available, because once you do the delayed cord clamping, more amount of blood goes to the baby, and there is some risk of the need for the phototherapy. Okay, so jaundice requiring phototherapy, lower risk with it, immediate cord clamping, that is expected. If you do the immediate cord clamping, jaundice risk will be less. Okay, so This is the point. Now, what are the factors influencing the placental transfusion? Prophylactic uterotonic drugs, they will reduce the PPH risk, but do not alter the final transfusion volume, but affect the speed and duration of the flow. But the final transfusion volume is not getting affected. They will affect the amount and speed of the flow. Okay. Now, these questions they can ask you, especially IV ergometrin. It has got a rapid uterine contraction, so transfusion is complete by 1 minute. So, but we are not recommended IV ergometrin at all. So what is recommended is IM oxytocin. IM oxytocin will act over a period of 2.5 minutes. IM ergometrin will act over a period of 7 minutes. And the placental transfusion is generally complete by 1 minute. So these particular medications will not interfere with the placental transfusion. Okay. So whatever the prophylactic uterotonic you are giving, either oxytocin or IM ergometrin, this will not affect the placental transfusion. Okay, because the placental transfusion is completed by 2 minutes. Okay, so this is one of the concept which you should learn from this. Okay, now what about the gravity? What happens when you keep the baby below the level of the placenta? At that particular time, obviously the gravity will increase the blood flow. If you like a cesarean section, you lift the baby more than 20 centimeter above, it will reduce the blood flow. But what does the guideline say? Venous flow to the baby is gravity sensitive and arterial flow is less sensitive. Okay, raising the baby above the placenta reduces the venous flow to the baby, possibly reverse flow. Okay, so when you raise the baby above the placenta, it reduces the venous flow. Lowering the baby below the placenta increases the flow to the baby, but no major net volume change, but it does not change the much volume. Without uterotonics, effect is more pronounced if the baby is catched up or the held more than 20 centimeter above or below the introitus. So if you do not use the uterotonics, then only there will be some change. But with oxytocin at term vaginal birth, placing the baby on the mother's abdomen or chest do not have any impact. So what happens? What is recommended when you do the delayed cord clamping? We place the baby on the mother's abdomen or the chest, and that even if it is above the level of the placenta, it does not have any impact on the placental transfusion. Okay, so we have seen about the uterotonics also, and we have seen about the position of the baby also. So it does not have any effect on the placental transfusion. So these were the couple of points which or concepts from this SIP you should remember. So historical practice is immediate cord clamping was part of active management. Uterotonics will reduce the PPH, but optimal clamping timing needs reconsideration. Preterms, what happens? Immediate clamping will increase the intraventricular hemorrhages risk, and mechanism will include hypovolemia or BP fluctuations and requires urgent RCT evaluation. Okay, stabilization with the cord intact. Drying, keeping the warm before separation is possible, and baby position near the uterus level acceptable to staff and valued by parents, and enables completion of the placental transfusion. So even if you keep the baby on the abdomen, generally there is no problem. Regarding the iron stores, what does the SIP say? Immediate clamping linked to lower iron stores for 3 to 6 months. That is why immediate cord clamping is not suggested. Long-term neurodevelopmental effects unknown, but should be studied. Iron deficiency in early life may cause irreversible delay. Then term births, deferring the cord clamping improves the infant iron stores, may increase the jaundice risk, but benefit outweighs the risk if phototherapy is available. So that is why in term infants, what we suggest is deferred cord clamping. It will improve the iron stores, may increase the mild jaundice risk is increased. However, phototherapy if available, that can be acceptable. Position, this we have discussed. Uterotonics, we have discussed, no effect. Position also no effect. Preterm birth, evidence is less clear. So these are the different concepts from the SIP. So that finishes our scientific impact paper on the clamping of the cord. Thank you.